We're going to show you an unusual situation where we stented both the SMA and the IMA. You can see the patient's history, a relatively young man, and the situation was that he had a very large IMA which was feeding the SMA, but an SMA stenosis. We opted, first of all, to approach this from the left upper extremity. We fused the CT images, and these images have used really to mark the origin of the superior mesenteric artery, the center line of the superior mesenteric artery. That's an overlying wire that you actually see here, and unfortunately it looks like it's inside the SMA. Here you can see a burn catheter which is being used to select the fused image. The fused images are used by taking the CT scan, and if you look on the right side of the screen, you'll see that what we have is our techs basically bring in and out the CT scan. They are working the CT scan to get us the best origins. The fusion and the center line marking is all done before we actually start. Now sometimes, of course, there's some deformity. It moves with respiration, and in addition to that, you also find that you typically once you actually do the angiogram, will kind of recorrect basically any errors basically in the fusion that's actually occurred here. But having that orifice minimizes the amount of dye that we've got to use. And at the same time, knowing where the wire goes and the trajectory is reassuring that we're actually in the target vessel. So here the SMA is actually being catheterized. It keeps going basically into one of the side branches, which you can see here. And so we're kind of redirecting it, trying to put it down the main trunk. More distally is the IMA orifice and the IMA center line. Below that is the bifurcation. So here we've crossed it. We've got the wire in right position. And now basically we shoot some down. You can see it's unusual stenosis, a little bit further away from the origin than is typical. And so the blue circle, which you can see there, which really looks like a blue line, is the first branch. And so we're choosing the length of the stent. In this case, I think we use a 6x21 to try and avoid losing that first branch of the SMA. Again, you confirm this, and sometimes you basically got to take it because of the proximity of the stenosis. This is a Gore VBX that has been inserted into that, and then kind of blow it up with a balloon. You can of course post dilate these things, and we've got it coming up into the orifice. Looks like we did lose one of those branches, and that's something you obviously got to keep an eye on post procedure. But you can see from the CT scan just how close the branch point was to that stenosis. We could have used a bare metal stent, and it might have saved some of these branches. Then we came down to AC and catheter and selected out the origin of the IMA. The IMA was huge. You can see there's some distal bare metal stents that are in there. And again, what we've done is we're going to catheterize the IMA. Much less often do we actually have to catheterize and stent IMA. Usually it's occluded rather than stenotic like this, but based upon its size. Again, you can see the first branch. In this case, we certainly don't want to lose that branch. Having some challenges in actually catheterizing this, and now you can see the center line, very reassuring where it is. And so once again, we used another VBX. We're exchanging for a rosin wire through a quick cross. That's the quick cross catheter that's been brought down there, probably going into that left colic branch. So wire has been removed, quick cross is in place. Typically we use a rosin wire in a situation like this to give a little bit more support. Probably should advance the sheath. I think we were maxed out at that point, but ideally we want that sheath pretty close to the origin. It gives an added level of safety if something goes wrong. So the decisions are, do you pre-dilate or will the stent track right into position? These stents really track remarkably well, slightly shorter stent, because truly an artificial stenosis is probably a 19. And blow it up into position. And it looks pretty good. On the completion angiogram, you can see all the branches are filling here. Maybe a little bit of spasm maybe in that branch where the end of the wire was, but we stopped at that point. Thank you very much.